My name is Dr Boiwka. I'm a hip and knee replacement specialist out of OrthoCarolina in Concord. Thank you for joining us. This is our June installment of our online webinar series. Today I'll be covering briefly knee arthritis and covering treatments all the way from non-operative measures to operative interventions such as total knee replacement and partial knee replacement. We'll talk a little bit about the diagnosis of knee arthritis, what to expect around joint replacement surgery, some frequently asked questions after and pertaining to joint replacement surgery, and then with the remaining time, I'd be happy to answer any questions the audience might have. So to start, a little bit more about me. My name is Dr Boiwka. I'm originally from Cleveland, Ohio. After high school, I went to undergrad schooling at Miami University of Ohio near Cincinnati. I then completed a dual degree program at Case Western Reserve University for both my medical doctorate and a master's in applied anatomical sciences. I then went on to do a 5-year residency program at University of Buffalo, New York, and then subspecialized further in hip and knee replacement, as well as redo or revision hip and knee replacements at the University of Texas in Houston. I've been with OrthoCarolina now going on 5 years, again, out of our Concord location, and I see patients kind of from the greater northern Charlotte metropolitan area. So first, what is arthritis? Well, when you actually dissect the term down, arthro meaning joint, itis meaning inflammation, and this is a broad term that kind of encompasses a variety of diagnoses pertaining to joint pain, and there's a variety of different potential causes. Everything from autoimmune causes such as rheumatoid arthritis, where the body's autoimmune system attacks the lining of the joint, can lead to damage to the cartilage that way. Also associated with other autoimmune conditions such as psoriasis. It can also be post-traumatic causes. If you had a prior fracture or broken bone that goes into the joint or around the joint, that can potentially alter joint contact forces or stresses. That can lead to accelerated wear of the cartilage. And then more nefarious causes such as septic arthritis or infectious arthritis, where bacteria or a fungus or an infectious organism makes its way into the joint and damages cartilage that way. Typically, though, when we talk about osteoarthritis, we're talking about, when we talk about knee arthritis, we're talking about osteoarthritis, and that makes up about 70% of the diagnosis. And this is more the wear and tear type of arthritis in the knee. And it's a progressive loss of the soft cushioning cartilage on the end of the joint, and then the subsequent reactive bone changes that you can see that we'll talk about a little bit further on. When we talk about knee arthritis, it's important to kind of keep the anatomy in the back of your mind. And we look at the knee in 3 compartments. One, if you can see there on the bottom left, being the inner part of the knee or the medial compartment. The second being the lateral compartment or outer side of the knee. And the third being the patellofemural compartment or kneecap joint. All right. I also liken this to osteoarthritis to the analogy of a tire. As the cartilage wears down, that's the tread on the tire wearing down, and you can't suddenly regrow tread. Again, indicating that's a progressive condition. All right. Osteoarthritis as a whole is one of the most common causes of disability worldwide. It's been the most common cause of disability in the U.S. for the past 20 years, and it's been estimated that nearly upwards of 80 million people will be affected by this condition by the year 2040 worldwide. It is a multifactorial condition, and you can kind of break it down into 2 subsets. One being that there's an abnormal cartilage that's present that can't handle the stresses of day-to-day activity and then leads to net cartilage loss with repetitive use. And then the other subset being normal cartilage that's present. Again, the body sees micro trauma on a daily basis. This cartilage gets injured, and the body releases factors and enzymes to help break down that cartilage in the attempt to build new cartilage, and it can't keep up with that net loss. Risk factors, there's a variety of risk factors for developing osteoarthritis. A big proponent of it, or a big portion of it, is genetic. If you have family members such as your parents or siblings that have a history of bad arthritis or bad hips and knees, well, you might unfortunately see yourself suffering from similar symptoms down the line. Okay. Also, genetic deformities to the limb or angular malalignments can increase stresses through the joint, and that can lead to accelerated wear and arthritic change. Weight is also a big predictive factor in terms of developing osteoarthritis, and it's also very important stemming into surgical management of the knee too, and we'll talk about that a little bit later. But our hips and knees see about 3 to 5 times the amount of stress and pressure as our body weight. So even carrying 10 additional pounds of weight can relate to a much higher rate of stress through the joint and accelerated wear. And then higher demand occupations such as construction work, dock work, things like that can take a toll going forward as well. So overall, in terms of signs and symptoms of knee arthritis, most common complaint is going to be pain. Compared to inflammatory arthritis conditions like rheumatoid arthritis, this tends to be more progressive throughout the end of the day and alleviated with rest or less so in the morning. It's a dull, achy, kind of throbbing pain, but it can have sharp exacerbations as well. And it's often accompanied with additional symptoms such as stiffness, as the capsule and the soft tissue structures around the knee can contract as the condition progresses. You can also develop crepitus or grinding or creaking sensation in the knee as that soft or smooth, glassy cartilage on the end of the bone wears away, leading to the more rough underlying bone, as well as bone spurs and the different changes to the joint can add to friction felt as well. You can also develop signs of instability, and that can be multifactorial in itself, whether there's an injury to the ligament after with progression of the arthritis, or contractures or stretching of ligaments. Also potential can be your body's natural response to pain, almost like touching a hot stove. You recoil and subconsciously want to pull away from that pain, causing the knee or leg to buckle. Also, you can develop swelling that waxes and waning in the knee, seen as that top left picture there, what we term as a effusion, often called water on the knee or fluid in the knee joint. And as arthritis tends to progress, if it doesn't develop uniformly through all 3 spots of those compartments in the knee, you can develop angular deformities shown down in that bottom photo, what we call genu varum or genu valvum, often kind of manifested as a bow-legged or knock-knee deformity seen in later stage disease. So ultimately, in terms of the diagnosis, we want to make sure that it's not another potential cause of pain, that it is in fact osteoarthritis that is your predominant complaint. So we want to make sure that it's not other orthopedic causes like meniscus tears, muscle strains, or fractures. There's also potential neurologic causes of pain that can be referred from the spine or from nearby nerves that can cause pain in the knee area, such as neurogenic claudication, which is a pain and crampiness in the leg when you stand up for a long period of time, caused by stenosis along the spine. You can also have vascular causes. Vascular disease can manifest as throbbing, achy pain. So your orthopedic surgeon is going to take a thorough assessment and obtain a thorough history, because a lot of times we can determine potential indications or potential causes for your complaints just based off of history alone. We're also going to be checking for those other accompanying symptoms: crepitation, loss of range of motion, deformities, and whether or not they're correctable, if there's any ligamentous injuries. And this all plays into how we treat arthritis, both conservatively and operatively. The mainstay of diagnosis, however, is going to be through X-rays, and we'll touch on that in the next slide here. But more frequently, we may or may not want to obtain advanced imaging such as a CT or MRI. This is pretty infrequent when it comes to osteoarthritis, and we're more so considering that in the setting of trauma or potential when you've had prior surgery near the joint, nearby hardware, deformities that we need to assess a little bit further. Also, lab testing, although infrequent with arthritis, can be done to help differentiate it from other potential sources such as gout or autoimmune causes or infection. In terms of X-ray findings, again, to liken it to that analogy of a car tire, as that cartilage wears down, you're going to see changes into the bone and on the X-rays. Cartilage on an X-ray does not show up typically, so as that wears down, you're going to see the joint space starting to close down and reactive changes thereafter. Things you can see include bone spurs, which are bony outgrowths on the side of the joint, and it's your body's natural reaction to try to spread out contact forces in the knee and try to decrease the pressure it's experiencing from that loss of cushioning. Also, you can see sclerosis, which is a thickening of the bone or hardening of the bone, where your body deposits more mineral in that area to reinforce the bone from the stress it's seeing. You can develop cysts in the bone as well, which is thought to occur after joint fluid can get pressurized into the bone after the cartilage starts to wear away, or potential from small microfractures over time healing and being replaced with that kind of cystic or cavity structure that we see on the x-rays. Looking at these photos here, you can see normal x-rays on the left of a healthy appearing knee. And as you can see on the right side here, you have bone-to-bone contact. In this case, advanced arthritis through all three compartments, medial, lateral, and patellofemural. And you can see the very prominent bone spurs or osteophytes throughout the knee. In terms of non-surgical management, in terms of arthritis, you don't have to have surgery. It is not mandatory, okay? And we recommend conservative treatment until symptoms are no longer tolerable. So ways to manage this, there's a myriad of options out there. The American Academy of Orthopedic Surgeons, one of our overseeing organizations, has conveniently put out what they term clinical practice guidelines. This is based on a summary of all the research and data available for various treatment modalities and their strength of recommendation accordingly. So some of the topics that they talk on would be walking aids, things from canes, crutches, walkers. And while this is present to prevent you from falling, which can lead to further injury, further pain, and further treatment, it can also help you reload stresses to other more healthy joints or other areas that may cause less pain. So typically we say when you're using a cane, we want you to use it in the hand opposite of the affected knee. Hot and cold therapy can be very effective in terms of pain relief. Cold therapy tends to cause vasoconstriction, helping with pain, helping with swelling, whereas heat can cause more vasodilation, helping with more stiff, achy, sore muscles and joints prior to doing exercises and activities. In terms of physical therapy and low-impact exercise, this has been strongly encouraged as it's been shown to decrease your pain by improving overall muscle function around the joint, improving posture, and preventing re-injury with day-to-day activities. Low-impact exercises such as aquatics, elliptical bicycle riding have been very, very helpful. Activities that are higher impact, running, jumping, can be more painful and more irritant to the arthritic joint. In terms of medication management, the mainstay of recommendation is going to be pertaining to non-steroidal anti-inflammatory medications. This has been shown to be very helpful in terms of mitigating pain with arthritis, but can have potential side effects in certain individuals. These medications are excreted through the kidneys, so patients that have kidney disease or stomach issues, stomach ulceration, or even potential chronic blood thinner use, we may not want to use these medications, although they are effective because of potential side effects. Another great alternative would be Tylenol, shown to have a great efficacy for managing pain with arthritis and a low risk profile. Opiate medications, the American Academy of Orthopedic Surgeons do not recommend using this routinely, as the overall risks associated with opiates are far greater than the benefits. You hear commonly in the news and the media about addiction, respiratory depression, and the potential sequelae for that. So we are not recommending routine use of opiate medications for arthritis. And in fact, we're looking at additional measures, as discussed in other talks, about how we can actually cut back on opiates after surgery as well, if pursued. Like I mentioned earlier, weight loss is a very helpful modality to assist in joint pain with arthritis. Again, losing 10 pounds can correlate to about 50 pounds of pressure coming off the knee, essentially, and that can be very helpful in terms of performing daily tasks. Other conservative treatment options include bracing. For certain types of arthritis, where it affects more so one side of the joint than the other, certain braces might be effective. For example, an offloader brace. If you have a worn out inside or medial part of your knee, we might be able to use a brace that helps redirect the force from the worn out inside of the knee to the more healthy outside of the knee to help with your pain. Okay. Sometimes even just over-the-counter neoprene knee sleeves and gentle compression, then you can make the knee feel better in the overall tricompartmentally arthritic knee. A very common way of addressing pain is injections, and there's a variety of different options available currently. The gold standard at the present time is cortisone shots or corticosteroid injections. There's a variety of different medications that fall into Sorry about that. Yeah, big storm just took out my power, and sorry, let me get back caught up to speed here. Hopefully we don't get disconnected again. Um, and kind of picking up where we left off, injections. These are a mainstay of treatment in terms of conservative management for knee arthritis. Again, there being a variety of different types. Corticosteroid injections are kind of the gold standard recommended injection at the present time, given their efficacy, relatively low risk profile, and overall affordability. The other options include gel injections or viscosupplementation injections, and these are a synthetic protein or sugar protein that's from our knee that we inject in there to help lubricate the joint, help decrease pain and inflammation. Studies have shown that compared to steroids, gel shots or viscosupplementation injections are not superior, and they do have a much higher cost for care. And for that reason, the American Academy of Orthopedic Surgeons doesn't recommend routinely using these. However, they can be effective in certain individuals, particularly patients that can't or should not have corticosteroids, particularly diabetic individuals or patients where we're concerned about hyperglycemia with glucocorticoids. There are also injections like PRP, which is where we take a sample of the patient's blood, we spin it down in the centrifuge and re-inject that into the knee. And that's been shown to be helpful as well in terms of pain and function for knee arthritis. Again, though, not superior to steroid injections. And due to the cost, it can be somewhat prohibitive for certain insurances. And actually, I take that back. Most insurances do not cover PRP injections at the present time. Another newer potential option for managing knee pain, especially in individuals that are avoiding surgery or not candidates for surgery, includes sensory denervation, or what we call genicular ablation. And this is where we find 3 sensory nerves to the knee, typically with ultrasound or with an X-ray. And we can go use a radio frequency probe to try to burn off that nerve and get you pain relief for a longer period of time. There is only preliminary data out right now about this procedure, but it seems promising. From the studies that are out right now, it shows that it can be effective as injections of corticosteroid, if not potentially more so, for up to a year or 2. But those nerve endings can reconnect and the pain can recur. Also, since it being a newer procedure, it's not covered by every insurance provider. Okay. Let's say you've tried conservative treatment and you're not sure whether or not surgery is the right option for you. Well, I personally like to ask patients 3 questions. Number 1, have you tried the conservative treatment? You don't have to have tried every single option, but we do recommend trying at least 2 to 3 options to make sure that we can try to improve your pain without the potential risks associated with surgery. Okay. Number 2, then, are you having difficulty performing the activities that you enjoy or need to do on a daily basis? And that includes work, hobbies such as golf, playing with grandchildren, lower impact activities. Number 3, are you having more bad days than good days? When your knee overall is really holding you back on a daily basis in terms of functionality and doing the things that you enjoy, that's when we should really start talking about surgery. And in terms of knee replacement, at the present time, that's the only way we can definitively fix osteoarthritis in the knee. We don't have the medical science right now to be able to regrow cartilage on a reliable basis, although hopefully with added time, medical science will progress to that point. The photos showed up on the slide right here show both a partial and a total knee replacement, okay? So on the left, you can see a total knee replacement. Again, going back to that 3-compartment model, a total knee replacement resurfaces all 3 parts, medial, lateral, and patellofemural, okay? And what we typically do is we resect or shave off less than a centimeter off the end of the bone at the end of the femur and off the top of the tibia, and we recap that with metal parts. And that can be fixed to the bone with a couple different methods, but typically we use cement, and that works like mortar to kind of lock into the crevices and cracks into the bone and the implants and hold it in place. In between the metal parts then goes a plastic bearing, and some surgeons put a plastic button on the undersurface of the kneecap to prevent bone wearing or coming in contact in that area as well. Alternatively, a partial knee replacement is shown on the right side here, and that's where we typically recommend for patients that have advanced arthritis in only one of the 3 compartments. In this instance, it's shown in the medial compartment here. And that way we resect a smaller amount of bone from both the end of both bones, and we recap it again with metal with a plastic bearing in between. Now, the benefit of a partial knee replacement is that it oftentimes feels more like your normal knee. It can, not guaranteed, but can be a little bit less or easier of a recovery early on, although I typically quote a same duration of recovery for both of my patients, from both a partial and a total. The downsides of a partial is that the longevity of the implant based on implant studies is a little lower, and predominantly due to 2 of the 3 other areas in the knee joint not being resurfaced, and you could develop worsening arthritis in those areas that might require further surgery down the line. Okay, when it comes to implants technology, I get asked frequently what approach I use, or what implants, what manufacturer, and in all, I'd like to tell my patients there's multiple ways to skin a cat. There's no front runner in terms of approaches, implant design, implant company, and there's a variety of considerations that a surgeon has to take into account when they are planning your surgery. Okay, everything from bony shape, like we talked about, nearby hardware, deformities around the joint, ligamentous concerns or ligamentous instability, potential for difficulties with exposure due to prior surgeries or scar tissue, bone quality concerns. And ultimately, I don't think patients should focus quite as much on the implant or approach that a surgeon uses, but have a discussion with their surgeon about coming up with a patient-tailored selection based on your specific needs and goals after surgery. All right. In terms of technology with surgery, there's one of the cool aspects of knee replacement and hip replacement is all the technology and technological advancements that are available and still ongoing. You might hear from everything from robotic assisted surgery, computer navigation, patient-specific instrumentation, and now newer technologies such as augmented reality and AI. Basically, these are tools to help your surgeon place and position implants according to your anatomy to the best degree possible. The benefits are that it's been shown that these improve accuracy of component placement. So let's say I want to put the component in about 3 degrees tilted to the left. These robotics and technological advances can get me there very, very accurately. But the missing link is, does that correlate to long-term improvements in patient satisfaction, function, and overall longevity of the implants? And that really hasn't been shown reliably to occur thus far in the data. There's also potential unique risks associated with these technologies, including increased costs. That's a great concern nowadays in our country. And for that reason, sometimes insurance companies don't want to utilize those technologies because of the added cost to it. There's also unique risks. For example, in robotic surgery, oftentimes we have to put additional pins or make additional incisions around the joint through the bone that can lead to potential problems at those locations, including infection or potentially breaking the bone through the pinhole. Okay. Debated is whether or not these technologies improve early recovery or decrease pain or minimize soft tissue involvement. And that hasn't been reliably shown in the data as well. It's thought that that can be correlated to less surgical exposure or less ligamentous releases or balancing to try to get the knee appropriately balanced during surgery. But again, overall, when compared to traditional instrumentation where we use alignment guides on the outside of the extremity or inside the bone to help align our cuts, there's no definitive superiority in terms of patient outcomes and longevity of implants. In terms of early questions that I get after surgery, so a total knee replacement or partial knee replacement typically lasts about an hour to an hour and a half in surgery. You're typically up walking within a few hours of surgery, and now more and more surgeries are being performed on an outpatient basis as we become more and more advanced with our pain management protocols, our anesthesia protocols, and our recovery protocols. So along those lines, more and more surgeries are also being done in the ambulatory surgery center, which tends to be an overall smoother and more efficient patient experience. When you get up after surgery, we'll get you up walking, typically with a physical therapist, and they're going to have you show you how to safely use a walker first that you'll be expected to use for the first few days to a week or so after surgery. Then as you feel more comfortable and more familiar with your knee, You're going to wean down to a cane, again, for maybe a few days to a week or two, and then ideally off of everything. Overall, you'll go home with a waterproof bandage as well, so you can shower typically 1 to 2 days after surgery, but we don't recommend full submersion underwater like swimming for about 6 weeks or so until the wound is fully healed up, no scabs or any cracks in the skin where water or bacteria can get in and potentially cause an infection. Another common question that I'm often asked about is, what can and can't I do after surgery? How much assistance do I need at home? And I like to tell my patients that you're going to be pretty independent after surgery. You will need some assistance, for activities that require prolonged standing or walking, such as standing at the stove for a prolonged period of time, preparing a meal, or maybe going out grocery shopping. But you will be up walking about your home, taking care of yourself, able to shower and bathe. So minimal assistance is typically required for about a week or two. Okay, and then in terms of pain management, we try to treat pain before surgery and after surgery with a variety of different medications. And most surgeons are using some sort of periarticular cocktail or a combination of medications that we typically inject around the knee to help numb up the knee and help with pain. That usually stays in effect for about a day or two after surgery. Some surgeons also use a catheter that goes into the knee that can leak anesthetic to help with pain for a few days after surgery. And then we try to manage your pain with a variety of different medications, not just opiate medication. We're going to use medicines like Tylenol, like anti-inflammatories, and potentially nerve modulator medications like pregabalin or gabapentin. In terms of recovery, overall, I tell patients to expect the majority of recovery, the first 80% or so, to occur within the first 3 to 4 months. But most patients tell me by about a month and a half to 2 months after surgery, they've kind of turned the corner and they feel better than they did before surgery, but they're not quite perfect yet. Okay. We can expect full recovery by about 1 year from surgery, and those are the little nuances, some stiffness, aches and pains in the knee here and there that gradually resolve with time. Most patients are back to most activities by about 2 to 6 weeks after surgery. In terms of driving estimates, everyone's a little bit different, and every surgeon has a little bit different criteria. Studies have shown that it takes about 6 weeks or so to get your brake response time back with your right leg. So I quote about that estimated for my patients, but oftentimes patients are back to driving sooner than that. One thing to keep in mind with a knee replacement, both in the early postoperative period as well as long term, is that physical therapy is crucial for your outcome long term. I tell patients that it takes over 50% of your outcome is in your own hands in terms of performing the exercises. In the beginning, your knee will be uncomfortable and swollen. We need to push through that pain a little bit to get the knee moving to get the best long-term outcome. Otherwise, the knee can stiffen up and scar in a term called arthrofibrosis, which can be very difficult to treat long-term. In terms of time off of work, that also varies. I quote to patients, usually estimate about 6 weeks off of work, but more labor-intensive work, such as construction work, roofing, things like that, where you're going up and down ladders, performing heavy lifting, might be closer to 3 months. In terms of frequently asked questions, in terms of overall implant longevity, registry studies out of Australia and other countries have shown that 90% of implants with a total knee replacement performed for osteoarthritis are still functioning well around the 20-year mark. Okay, for partial knee replacements, that's a little less, closer to 80 to 85% at the 15-year mark. And that, again, is stemming partly due to progressive arthritis elsewhere in the knee and potential further treatment for that condition. In terms of activities, what you can and can't do after a knee replacement, we recommend avoiding high-impact things like running, jumping, so marathon running, basketball, high-impact plyometric activities like that. But otherwise, lower impact activities, tennis, golf, pickleball, bicycling, swimming, even skiing in some cases is A-okay, and go for it. Okay. A final question that I got asked from patients is, what should I expect from my post-operative knee compared to my non-operative knee? And we have to be honest here. You can't necessarily compare apples to oranges. We're taking metal and plastic parts off the shelf. We're trying to marry it to your anatomy as best as possible. So there will be some subtle differences, okay? One thing to expect is maybe episodic painless clicking and tapping in the knee, because the knee is a complex joint. It doesn't just flex and extend. It also rotates and pivots and translates front to back. So you want about a millimeter or two of play in the joint when we do a knee replacement to allow for those appropriate movements. Okay, so that might manifest as some clicking and tapping from time to time, but should not be very frequent and should not be painful. Okay. Also, some patients will experience a chronic numb spot about the size of a $1/2 along the front outer part of the knee down by the patellar tendon. Sometimes that stays permanent, sometimes it fully goes away. Also, some patients, not all, but some say they can be a little uncomfortable to kneel on your knee. Anatomically, you can do it just fine. You're not going to hurt anything, but it might be a little sensitive due to, again, the altered neurologic nerve endings in that area and the scar tissue. And good studies have shown that you can go back to kneeling just fine by kneeling on some padding and some pillows and getting more accustomed to it over time. Also, like I mentioned before, that last 20% of recovery can take upwards to a full year to fully take place. So you can notice some mild swelling and warmth in the knee for up to a year. But overall, after that, it should settle down. Okay, so that's it for my presentation. I'm happy to answer questions at this point in time. And again, I apologize for the technical difficulties there. So first question, I'm 90 years old and have a knee filled with arthritis. What is my best course of action? So this is a good question. This is a very common patient that I see in my office. And first, we have to kind of see what has been tried first. What activities are limiting you in terms of, I'm sorry, what is your knee limiting you from doing in terms of activities? And potentially we can just mitigate our activities first to help with the pain. Number two would be considering using anti-inflammatory medications or oral medications appropriately based on your medical conditions. And then considering possible injections. And we can repeat steroid injections every 3 months as long as they're effective. And gel injections closer to 6 months as long as they're effective. And you can even potentially alternate those injections based on their efficacy. I have received 3 knee injections and received no relief from pain and I'm now using a walker to get around. Is this the only thing left for me is knee replacement? So that's a good question. And that kind of stems back to the diagnosis of what exactly is causing your knee pain. It might be knee arthritis. It might be referred pain from elsewhere. Another frequent thing that we see as hip and knee replacement surgeons is patients coming and complaining of knee pain, but it is in fact referred from the patient's hip. So we oftentimes have to check the joint above as well to make sure that that is not in fact the cause of your discomfort. So really for this patient, I would recommend a thorough reevaluation of what's been tried, the imaging that's been performed thus far, and what joints have been looked at, and then reevaluating where to go from there. After having arthroscopic surgery for a torn meniscus and early stage arthritis, what kinds of exercises and foods can actually help with healing and keep the arthritis from getting worse? That's a good question. Meniscus tears and osteoarthritis tend to go hand in hand. In fact, having a meniscus tear and even potential surgeries for meniscus tears can accelerate arthritis development down the line. So in terms of activities, like we talked about, lower impact exercise, maintaining a strong musculature around the knee, quadricep muscles in particular. And in terms of foods, I can't say there's necessarily one diet or one particular recommendation that stands out from others. Typically, we recommend for patients to maintain a well-rounded, healthy diet, robust and leafy green vegetables. Certain foods have been attributed with anti-inflammatory effects like omega-3s, and antioxidants. However, based on the orthopedic literature, I can't say whether or not this will actually make a long-term meaningful difference, but the overall risk of pursuing these diets is very low, and it probably would be beneficial to your overall health as well. I have knee arthritis and bone spurs. Does this qualify me for a knee replacement? In brief, potentially. Typically, we try to avoid surgery until we've tried all the other conservative options and that the x-rays show end-stage arthritis, where it's that bone-on-bone contact. So, depending on how progressed that is on your x-rays, you may be a potential candidate for a knee replacement, but we need to assess a little bit further. At what point do injections no longer control discomfort and then surgery becomes the answer? That's a good question. And really, it's patient specific. I have some patients that get injections and they report improvement for up to a year. I have some patients that have an injection and get little to no improvement or improvement for only a few days. Really, it's something to try first before we start considering more surgical options, and I would consider repeating those injections as long as they're effective for at least 1 to 3 months, and effective in terms of managing your pain, and you're still able to perform the activities that you need to or want to on a daily basis. Can I still do cross training and run after knee replacement? Good question. And every surgeon is a little bit different in terms of their recommendations for activities after surgery. Historically, though, we typically recommend against high impact activities like cross training and running. Your knee will be stable enough to hold you for that. You know, God forbid a grandchild or a pet runs into the street and you have to run after them. But I wouldn't recommend picking up marathon running anytime soon after a joint replacement. Do women have a harder time healing from knee replacements than men do? Good question. Studies have shown that no, in fact, they don't. While women are more common or more likely to have knee arthritis as a diagnosis, in terms of recovery, satisfaction after surgery, there's been shown to be no significant differences. How long does a knee replacement last? Good question. Yeah, so again, based on the registry data, again, this is based off of implants and documentation of surgeries that were performed 20 years ago. 90% of those are still functioning well at about the 20-year mark. Now, that could be longer as implants improve in terms of bearing surfaces, fixation methods, and protocols in that regard. How long do shots last for? Again, kind of similar to the prior question. Everyone's a little bit different. It can last from anywhere from a few days up to a year or so. I'm 72 and have arthritis under the kneecap. Is it possible just to remove that and avoid a total replacement? Excellent question. Yes, they do make a unicompartmental or partial patellofemural knee replacement, and that might be a good option for you based on your clinical assessment and Xray findings. I've had both knees replaced. Why do I have soft tissue swelling? Doesn't hurt. I thought it meant to lose weight. That's a difficult question. Swelling in the knee can be from a variety of causes. It can be, again, fluid inside the knee, what we call an effusion. That can be signs of instability in the knee. It can be signs of bleeding in the knee if you're on a blood thinner. And then there's potential causes of swelling outside the knee as well. Things like lymphedema, where our body retain more fluid in our dependent posture in our lower extremities predominantly due to potential issues stemming from our vascular system, leaky veins, or kidney issues or heart issues. So that's something that might need to be further assessed on an individual basis by both an orthopedic surgeon and maybe your primary medical doctor as well. Is there cases where the replacement has to be replaced? Yes. Knee replacement, unfortunately, doesn't last forever, and failures can occur. The most common causes for knee replacements needing to be redone include infection. Okay, so that's why we take a very strong stance trying to prevent infection, optimizing our patients before surgery, and try to minimize that risk. Number two would be loosening, okay, where the parts debond from the bone. Again, potential risk factors for that would be high impact repetitive wear, or repetitive activity, running, jumping, things like that. And the third potential cause would be instability. And there's a variety of potential reasons for that. Partly it could be due to damage to nearby ligaments. It could be due to the components not being necessarily put in the right position right off the bat, or wear or tear of the parts. So it needs further assessment by a trained joint replacement specialist. 7 surgeries on the same knee. I'm only 49, but was told to wait till 50 to get a replacement. If I have daily limitations to pain and activity, can I finally get replacement? Good question. I think historically, we've always been trained to hold off on surgery for as long as possible. And that's based on those longevity studies that it's not going to last forever. It's metal and plastic. It doesn't have any restorative capacity to it. And so at some point, yes, it likely will wear out in a younger individual. Also, historically, based on the studies, patients that are younger, predominantly men under the age of 55 or 50, tend to have the lowest survivability of their implants, again, thought to be due to higher impact activities and demand. So age is, yes, it's just a number, but there's a variety of factors coming into play here in terms of medical comorbidities, surgical risk, and what goals you have for your knee afterwards. If it's returning back to lower impact activities, walking, taking care of family members, golfing, things like that, or if we're trying to get back to high impact stuff, competitive running, high impact sports, we might need to mitigate our expectations a little bit. I had a left total knee replacement, had clots and pulmonary embolism after surgery. I'm scheduled for right total knee replacement. I'm under the care of a vascular surgeon and I'm currently taking Eliquis. Do you have any suggestions? Good question. And this is a scenario that we do see from time to time. Hip and knee replacement, not just knee replacement, are both associated with developing blood clots after surgery. So it's very important that we take preventative measures to mitigate this risk. In an individual that's had a history of a prior blood clot, especially one that goes up to the heart and lungs, you're at higher risk for developing that going forward. So typically, that's a thorough discussion that needs to be had with your orthopedic surgeon and potentially with your vascular surgeon, potential risk factors that can be addressed prior to surgery. If you have a hypercoagulability disorder, we may have you do certain measures to try to mitigate that risk, having you use certain blood thinners such as Lovenox up to the night before surgery, and then starting the Eliquis after surgery. In some cases with patients that have a history of multiple blood clots up to the heart and lungs, we might consider putting in a removable filter in the vena cava, or the main blood vessel in your chest, to prevent those blood clots from going up to your heart and lungs, because that can be fatal. While a blood clot that develops in the leg is painful, it's not necessarily life-threatening until it travels up to the heart and lungs. I'm 69 and have bone on bone. I get gel injections every year. I have not been able to kneel in over 6 years. What do you recommend? Good question. And in terms of the injections and kneeling, this is, again, a discussion that needs to be had in terms of what activities are we trying to get back to with treatment. If it's just kneeling, like I mentioned before, there is a subset of patients after a knee replacement, both partial and total, where you can still have some discomfort with kneeling. And I want to make sure that your goals are in line with the outcomes of surgery. If we haven't maybe optimized treatment, okay, maybe we're only getting gel injections, we haven't tried some of the other measures like oral anti-inflammatories, or maybe some room for improvement there as well. But that would need to be a case-by-case discussion with your treating provider. Good question. Patellofemural replacements historically have a lower track record of longevity. Now, historically, that was more so due to earlier implant designs where the components would loosen up, or the kneecap would dislocate out of the groove of the femur. So there's been some improvements in terms of implant design and procedures and how we place those implants. It's very crucial that we get those implants in a good position. So a lot of times for those procedures, we may use patient-specific instrumentation where we get a CT scan of the knee, and that allows us, or the company, to make custom-fit cutting guides that fit onto the end of the bone so that we don't have to make manual measurements. Or we may use robotics where we can get a CT scan or accurate measurements of the bony surface, and they're precisely put the implants where we need to try to minimize those risks. All right, thank you all for attending. I appreciate you hanging in there with the technical difficulties. Again, my name's Alex Boiwka. Just a reminder that this talk will be saved on all of our social media platforms as well. Thank you and have a good night.